Good afternoon, everybody. On behalf of Karyopharm Therapeutics, I want to welcome you to our program today. My name is Julie Butt, and I am a nurse liaison with the Great Lakes region at Karyopharm. We have a really exciting program planned for all of you today, and the objective of this program is to engage our panel of experts in a discussion regarding the aspects and the importance of a supportive care team throughout a patient's cancer diagnosis and their treatment journey. I want to start off by introducing our panel members. So we have joining us today our oncology nurse expert, Dr. Beth Feynman. Beth is a practicing nurse practitioner in the Hematology and Oncology Blood Disorders Center at the Cleveland Clinic. Next, we have Karen Smith. Karen is our registered dietitian. She is the manager of dietary services at Texas Oncology. Our expert oncology pharmacist joining the panel today is Ori Leblebian. She is a clinical pharmacy practice administrator at the Dana-Farber Cancer Institute. And last, however not least, is Nicole Peak. So Nicole is a licensed social worker with the Adult Hematology Hematopoietic Cell Transplantation Division at the City of Hope. So welcome to all of our panel members, and welcome to all of you that are in listen-only mode. We're really looking forward to this engaging conversation on the importance of a supportive care team throughout a patient's cancer journey. So with that, I'd like to just jump right into the first question. So the first question is surrounding which disciplines encompass a patient support team. And I know this differs from office to office and from institution to institution. And not everybody has the advantage of having a multidisciplinary team making up their patient support team. So I'd like to throw this first question to Beth first, and just kind of talk us through what it looks like at the Cleveland Clinic.
Thank you so much, Julie, and thank you for having me today. So this is a question near and dear to my heart. One of my passions in managing patients with multiple myeloma is encompassing the multidisciplinary team. So as an advanced practice nurse, I think I play a key role in helping to assist in the diagnosis and management of various acute and chronic illnesses, right? But there's also social workers, physicians, nutritionists. It really takes a village to manage these patients. So from the time that they are diagnosed and enter the Cleveland Clinic, we try to absorb all of these resources and provide them to the patients in a stepwise fashion. You can't throw everybody at them at the beginning. You just want to do a little bit at a time and let them know that the resources are there for them.
Excellent. That sounds great. So Karen, I'd like to go to you next. So what does it look like at the Texas Oncology?
So very similar to Beth's response. And again, thank you so much for having me this afternoon as part of this panel. And I'm especially grateful to be part of this panel because I think that this represents such a great multidisciplinary team here that is ideally replicated in the clinics. So certainly the medical team, the doctor, the advanced practice practitioners, the nurses, social work, pharmacists, dietitians, and then if possible, people who have specializations in physical therapy or occupational therapy are always nice to bring in if possible.
Absolutely. And I know Texas Oncology has, I think you had mentioned before, like 20 satellites.
So we have about 220 actually.
220. Okay, that's a big difference. So with that being said, as far as a patient support team at the other 220 satellite offices, do they try to encompass the same multidisciplinary team approach there as well?
We are actively working on making sure that every patient has what they need to get through all of their treatment with any questions or any resources that they need along the way.
Gotcha. And then Ori, I'm going to throw it back to you. The same question. What encompasses a patient support team at Dana-Farber?
So again, every team is a bit different, but at least in myeloma, we have the core team. Of course, it's the doctor, the MD, the advanced practitioner. We have the nurse navigator and the pharmacist. And then additionally, if needed, patients, if they have nutrition questions, we have a nutritionist, social worker, and we are lucky to have a resource specialist too that does all our prior authorization and patient assistance programs, because it's very important for patients to actually be able to access and get their medication. So we are lucky to have them part of our team.
Oh, I couldn't agree more. And those individuals, I mean, just to have the job and with all the patient assistance programs that are out there that are offered, that is a job in and of itself. So that's really helpful. And then Nicole, certainly last but not least, again, I'd love to hear what you have to say in regards to the City of Hope, what that looks like there.
Well, thank you again for having me. This obviously is a topic that is near and dear to my heart as well. So at City of Hope, clinical social work is integrated into supportive care medicine. So we actually have 12 different divisions in supportive care medicine. So that ranges from integrated pain, palliative care, social work, psychology, child life services, spiritual care. So it's a large department, and we follow inpatient, outpatient. So we really try to be pretty available to patients through the trajectory of their treatment, from diagnosis, and that could be weeks, months, years, getting to know people and being available to them.
That sounds fantastic. I love that. This other question is a really good question, and love to hear your feedback on this as well. And that's in regards to some of the potential challenges that your patients may encounter over their course of treatment. And what supportive measures are in place to guide the patients through these challenges. So Nicole, I'd like to kind of throw it back to you, being the social worker. So as far as your discipline, what types of challenges do you see patients encounter as far as social workers?
Sure. So that really can differ on a few things in the context of, initial diagnosis through treatment. Because I work in hematology, I work a lot with transplant patients. I think, initial diagnosis for all of our patients is difficult. So being connected with a multidisciplinary team is so key. So it's really whole person centered, not just looking at the treatment, but quality of life and symptom management, and making sure that patients are asked about those types of things by various providers. I think, some people are really limited in the scope of who they have available at clinics. So, I tell people really all the time, please ask patients about, how we can best support them, how they can best support them, who can I link you with for services. Some things are not in everyone's scope of practice, but knowing who to refer patients to for dietary services, talk to a pharmacist about that. I'm going to talk to your advanced practice practitioner about that. And so they feel comfortable knowing that this person can link them with the correct services. So diagnosis through survivorship, and in some cases, end of life services, but really engaging them in discussion about that.
Yeah, and you mentioned initial diagnosis, it's got to be so overwhelming at first when somebody gets a diagnosis of any kind of cancer. And just to hear that, I'm sure everything else goes out the window after they hear what their diagnosis is. So making sure they fully understand, just what's all entails in their initial diagnosis. Survivorship that you mentioned, do you guys have survivorship clinics designated for your patients?
In the outpatient setting, we do not have a specific one for hematology. I think that that's something that we've spoken about for a while. We do have a couple different programs that are focusing on quality of life through a supportive medicine program. But I think, when patients are seeing their physicians in clinic, they tend to refer to our pain management services, palliative care for a lot of that, those types of issues. And we do incidentally do a really neat clinic called the Graft versus Host Clinic for our patients with acute and chronic GVHD. And that's wonderful. Social work actually attends those clinics every Friday. So we get to help support patients and some of those impacts to quality of life, along with the physical symptoms.
Yeah, and quality of life is so an important topic to talk about, I mean, because if you don't have a good quality of life, then that just
Absolutely.
affects everything. So Beth, I'd like to throw it back to you as far as the nursing role. What are some of the potential challenges you see your patients have to deal with?
Well, that's an excellent question. And unfortunately, at diagnosis, it might change when they're newly diagnosed versus heavily pretreated. Some individuals might have more physical, social, or financial troubles that might be worse at the beginning or worse after multiple lines of therapy. We do have a survivorship clinic, but we also try to, at each encounter, look at all of the risk of DVT, any weight loss or weight gains, and reassess their status. And that's where I think that the nurse navigator, pharmacist, and social work, including the multidisciplinary team, is so important, because they might have different eyes on different facets of that patient care. But we try to address all of their needs at each encounter, not necessarily the every 6-month survivorship visits that we might have.
Gotcha. And you mentioned financial. So let me ask you this, as far as patient assistance programs that are offered, obviously through the pharmaceutical industry, but other types of patient assistance programs, do you utilize those types of programs?
Absolutely. We are so fortunate to be a part of a large multi-hospital system. And so we do, I think, maybe have a little bit more access to certain grant funding, internal and external. I'm always referring patients to like the Leukemia and Lymphoma Society, American Cancer Society. We have copay assistance for parking reimbursement through private grants because parking can even be troublesome. And then we have the pharmaceutical companies are fortunately will be able to share some of their, co-payment assistance and even, like I said, transportation for monitoring. So that's really important to tap into. And I've had patients that come for months and months and years even, and unfortunately weren't linked into those resources. And that makes me very sad. So having a team approach to care and providing these resources is important.
Well, I love to hear that you guys utilize those different types of programs, specifically the patient assistance programs, because, patients need those kinds of assistance, even though they may not talk about it freely, they certainly do need that every once in a while. So that's good to hear. And then Ori, as far as, pharmacy related challenges that you see patients, possibly can run into, what does that look like as far as on the pharmacy end of things?
Yeah, so as Beth said, the challenges are different if it's newly diagnosed or relapsed patient. But most of the time, as you said too, these patients are coming in and you're giving them so much information, especially the newly diagnosed ones. And you're like, oh, you're going to take this regimen that has 3 medications, 5 extra for supportive care. So these patients really get overwhelmed. So I usually, that's why I usually will do the counseling for the patients, counseling the day of, the day after, checking on them. I mean, that's the only way we found, because most of the time the patients come, even when I talk to them, they're like, nobody told us this, but I know someone told them that. But because they're so overwhelmed, it's just hard for them to hear. And on the other hand, when it's more of the relapse patient, 4th line, 5th line, they'll be like, oh, I'm fine. I know everything, they're totally fine with. So it's basically engaging with the patient and understanding, what do they know. And sometimes when they don't know what to ask. So that's the part where I have like the basic questions that I'm always going over with them to make sure, they have the minimum understanding so that they know what to do. Like the minimum is, do you know where to call, when something happens. So those are all things that trying to overcome by doing more teaching and counseling for them.
Yeah. And as far as when you had mentioned, you call and you check on the patients, how often are you doing that?
So I usually do it at the beginning when I talk to them, like right before they start. It's either like the day before they come in for their therapy, and then I check on them the day after to see if they have more questions. And then because they're usually seen on a regular basis, they come back in like 2 weeks or 4 weeks, unless they need me to. They have my information to call if they need to. But basically, I just put it back on the advanced practitioner or the MD saying, okay, this is all set. These are what the questions came up. If there are any issues that came up, we try to solve it right at that time. But the follow-up is usually done when they come back to clinic.
Gotcha. I love that. And then Karen, I'll go to you as far as, dietary goes. What are some of the challenges that you see patients encounter?
So definitely to echo Nicole, Ori, and Beth's comments that people do face such a variety of challenges at different phases of their treatment and of their journey. And reiterating that they can always come back and ask for help and ask for other resources is definitely something that is very important for patients to understand as they go through. So one of the things that I see a lot being a dietitian is kind of the taste changes or weight loss that people can sometimes experience throughout their treatment. And there are some very good interventions. The American Cancer Society, the National Cancer Institute have great patient education booklets that address some of the side effect management. And one of the biggest challenges that I'm familiar with which is related to nutrition, but sometimes absolutely needs a multidisciplinary approach, is the fatigue that people encounter as part of their treatment.
Yeah.
And that can impact how well people are able to cook for themselves, or even how much they're able to chew or enjoy their food, or even the amount of food they're able to eat at one time.
Yeah.
So that is one of the things that I kind of focus on a lot with logistics with patients and caregivers with when they come see a dietitian.
So you had mentioned educational material. Do you find the educational material, either for yourself or for patients, that's being offered through the pharmaceutical industry, do you find those types of tools useful or helpful?
That's a good question. I think it's definitely dependent. I've seen great materials released for patients, and I know that the folders or binders that people get with new medications are really good at addressing the specific side effects that come along with specific medications.
Yeah, gotcha. Good to know. I think another really important question to ask all of you is in regards to when a patient is initiating a new treatment. How do each of you set expectations for your patients when they start a new therapy? So, for example, if they have to come in frequently for their treatment protocol or their treatment regimens, how do you guys set those expectations? So, I'd like to hear from Beth first, if you don't mind. Just kind of giving us your feedback on that.
Thank you. I think there's a distinction between the newly diagnosed patients and the one that's, relapsing, first relapse, second relapse, slow biochemical relapse, and then end of therapy, more salvagey regimens. But the frequency of visits up front is very clearly laid out. The duration of therapy, we know now in multiple myeloma 2021, it's ongoing treatment to suppress malignant clones is kind of the way that we manage myeloma. But we try to make calendars. I think adherence is so challenging, and I'm always making out calendars to try to remind them when they leave the office, here's your next appointment. This is what our expectations are. And inevitably, especially if during this crisis, they coming by themselves might not remember how often they're supposed to get lab work or remember to take frequent meals and take this extra vitamin. So I think reinforcing the plan at each visit and in between visits. And again, I keep going back to this multidisciplinary team, but it might be that nurse that can see them in the infusion area while they're getting another medication in between our visits, as well as the pharmacist and all of the team members that can help reinforce these important items.
Yeah, and I love that you mentioned personal calendars. I mean, I can only imagine how helpful that is. And like you had all mentioned before, I mean, these specifically for multiple myeloma, these treatment protocols can be so complex, and they're not always the same for every day. And the weeks change as well as they go along their treatment regimen. So having a calendar, a personalized calendar, I'm sure is extremely helpful for those patients.
And can I just add one more thing, Julie, not to interrupt, but I think that calendar can also be brought back to each visit. Voluntary, of course, and if they're having side effects or symptoms, write it on the back of that calendar so that they can discuss it at their visit.
Absolutely. Good point. Good point. So Nicole, being the social worker, what are some of the, how do you set expectations for your patients starting new therapies? And like Beth said, it does change from initial diagnosis to the relapse refractory setting, but would love to hear from you.
One of the things that, we don't often go to every clinic visit, but what we are called in for is to really, ask patients or really try to identify what those barriers are. So for some people, it's medical literacy, especially when they're newly diagnosed, really kind of gauging what their understanding of what the treatment expectations are from the physicians and the team. Involving the families, I think, important, especially with COVID. Most of our patients are coming to these appointments by themselves. And often the family members, would come with them previously and could help take notes and be that extra set of ears, especially if it's a spouse or partner or caregiver. So, I've really tried to encourage team members and nurses to check in with the patients when they're coming to clinic or they're having these meetings. Can we get someone on the phone so there's another set of ears, someone you trust, maybe your caregiver, your medical power of attorney, so they're in the loop. It just depends. Some patients are okay with that, some are not. So I really, encourage the team to do teach backs and ask them, okay, so can you tell me a little bit about what your understanding is of things? So there's some different ways to really, gauge how well the patient understands that and the treatment expectations. But I think really, involving the patient in, taking notes, doing a calendar, but also really trying to engage the support system if they're not going to be at that visit on the phone, or maybe to follow up with the doctor or the team.
Yeah, and I love that you mentioned the caregiver, because I know a lot of times our caregivers get forgotten. And I know, when we talk to our healthcare professionals, and we constantly talking about the caregivers and making sure that they're included, because sometimes, these myeloma patients can be very all-encompassing, and the caregivers are there. They're the ones taking on the brunt of everything, and they're trying to remember everything and taking care of the patient. They're not taking care of themselves. So I love that you really focus on the caregiver, because they, like I said, sometimes they're forgotten, and they're such an important piece of a patient's journey, for sure. And then Ori, I'd love to talk to you as far as pharmacy related, expectations when patients are started on new therapies. Talk a little bit about that.
Sure. Expectations, I think there's like the first impression on the patient. So basically, if a patient comes in and we prescribe them some medications, we have to set the expectation where, this might take a couple of days to be approved, because now suddenly they're like, where's my medication? Why didn't I start? So that's one of the most important things I've seen, so that the patient from the beginning knows, these take time, there's insurance coverage, and then it could take based on assistance programs or whatever is needed. And then the other thing is, I give calendars to my patients with all the dates, but, telling the patient that, we are a bit flexible. It doesn't mean we're suddenly stopping your life at this moment and you're like, you have to come in every Friday for treatment. If someday you have to come in on a Thursday or Saturday, showing them that, there are these minimum expectations, but, some things are flexible, because we know everyone's human and you can have something on those days. So it's okay to just let us know. And then, of course, the communication, asking them to be like open communication between us. If you're having any side effects or anything like that, please call us. If you want to change something that you're having, or if you want to change your appointment, please let us know. And, having that conversation with the patient definitely, helps them understand that, it's not like a strict thing that I'm following. There's flexibility. I'm still going to have my quality of life as much as possible continue.
Yeah. And Ori, you bring up a really good point in regards to the time it takes to get the medication in hand. With oncology, this is a completely different beast versus going to your primary care physician. When they write the prescription, you go to down the street to your local pharmacy and you get the medication that day. So to your point, it takes several days, because these are specialized types of medications where it has to go through an authorization process, and it can take, several days before they actually get the medication in hand. So I'm glad to hear how you educate your patients and tell them, right up front, don't expect to get it on the same day. It'll take a couple days to get to you. So I love that you
add to that too. Yeah. So, and to add to that, it's the expectation of how long they're going to be in clinic. You're going to be here for a couple of hours. It's not like, oh, I'm walking in and out in an hour. We explain to them, there are labs. There's a time to make the chemo and everything like that. So having those conversations too, saying, expect to be here for 3 hours or 4 hours or a full day based on your treatment, that's important too for the patient to know.
And just to piggyback off that too, in regards to lab work. So when a patient just comes in for their labs, they're not there for an actual clinic visit. When they're just there to get their lab work, how do you walk them through that? Do you just basically say, listen, you're just going to come in, get your lab work. You're not going to see anybody. What kind of conversation does that look like?
Usually, if it's in the mid treatment section, if it's a patient who's on an oral medication, they still need to come in for their labs. It's usually go to this floor, get your labs done, and then go home, and we will call you back within a couple of hours. And then they all have the phone number just in case if something happened, they want to call in. They all have the online version where they can check in their own labs if they want to. So there are different options that the patient can do, but the expectation on those days it's quick, much quicker than if you're getting actual chemo. Definitely.
Yeah, I appreciate those short days, right? I'm sure. Mm-hmm. And then Karen, certainly last but not least for you, I'd love to hear what you, as far as setting expectations for your patients when it comes to the dietary piece. What does that look like?
So certainly one of the most important expectations is that there are resources available. It's a tough balance between giving people a lot of information that many side effects can happen during their treatment versus because you don't want to scare people by saying, well, you could get nauseous, you could lose weight, you could, all these things could happen. Because for some people, they have minimal side effects and then they don't need as much of the support.
Exactly.
But letting people know that they could have side effects, that if they do have these side effects, there are resources available for them to manage them. Some of them can be managed almost completely, and then some things may not be perfect or exactly like they were before treatment. So that's always a little bit of a counseling back and forth between kind of gauging how much patients are able to absorb. If you start listing long lists of side effects and you kind of notice some tension in the room, maybe you're like, okay, well, this is you. If you have these side effects, these are the numbers to call. These are how we can manage them. We're here for you. Or some people do want a lot of information up front, and that's when these booklets are really good. And just to kind of return to Nicole and what Nicole and Beth were talking about too, with the calendars and caregivers not being able to come to visits, it definitely, I've seen it impact clinics with people on phones, and but one of the other tools that we certainly have now is telemedicine. And that's been really helpful because you can actually, when you do these telemedicine visits, getting caregivers, even far away caregivers, sometimes can join the calls, or patients can actually hold up what vitamin or what mineral they're taking or what drink they're taking as far as like a nutrition piece goes. So it's been hard not to have the caregivers as much in clinic, but the advent of telehealth has allowed some other interactions, which are nice.
I agree completely. And especially in this COVID area, to have telemedicine has got to be so helpful, specifically for multiple myeloma patients. I know a lot of them are still very apprehensive of actually going into the clinic, so I get that. And the other thing that I was thinking about when I was listening to what you were saying, specifically with side effects, a lot of times these patients get very overwhelmed when you're going through the list of side effects that can potentially happen. So how do you navigate for each patient how much information to tell them and how much information to kind of hold back, because you don't want to perpetuate an anxiety in them? So how do you try to balance that for your patients?
Well, that's certainly, it is very helpful to have the education for specific medications and to try to stay up to date as much as possible on the side effects. Because you can, if you know that diarrhea is a big side effect of a certain medication, you can tailor a little bit more towards that. If you know that weight loss or nausea or taste changes are more predominant, you can give a little bit more information about those up front.
Yeah. And so Beth, just to kind of do the same question, I mean, how much information, like I said, sometimes patients you see that get like a deer in the headlight after you start talking with them. So how do you gauge on how much information to tell them?
That's an excellent question, because when you're first meeting somebody that's newly diagnosed with myeloma, you want to give just enough information for them to understand the risks and benefits and alternatives and support themselves. We always want an extra set of ears, and so that's where the telehealth visits or FaceTiming a caregiver or a loved one in the COVID era is really important. You get to know your patients, though. Some patients are always on the internet and want to have more information. I try to give everybody the same level of basic information. For example, I say, these are my top 3 side effects that you may or may not experience, and give them the written information, and you just do the best you can, and give them the triggers to call if you're having any questions. We're all here. I've heard numerous on the panel say they have the number to call. We also have the portal. They can send us a non-urgent message as well, to just keep the lines of communication open. And even if it's a minor side effect, it might be important for us to know so we can manage it.
Yeah. And that's a good segue to this other question I have in regards to what warrants a phone call to your office. I mean, when you're educating your patients, specifically newly diagnosed myeloma patients, when you're educating them, what do you say? This is when I want you to call me. This is when you really don't need to call me. So what warrants a phone call when you're advising your patients?
Yeah, absolutely. And similar to most of those on this panel, I give a piece of paper. At each visit, they get their little summary, and it says if you have any fevers greater than 100.4 Fahrenheit, shortness of breath, chest pain, new back or bone pain, anything out of the ordinary, unexplained weight loss or weight gain, anything that's not normal, give us a call or send us a message. Let us know what you're experiencing. It also will tie back into that education about the frequency of visits, lab or in person, and tracking their side effects. Symptom diaries, I think, are very important in supporting our patients. And I ask them to track their symptoms. For example, diarrhea from certain medications might be more common. So let's try to see what you're eating and not eating, et cetera, and try to avoid the foods that are triggers. And so, just pulling in the nutritionist, dietitian as well in that case, and then the pharmacist to rule out any competing medications for their symptoms, et cetera. So yes, it's all very important.
Exactly. I was thinking as you were talking, Beth, I know some of these patient assistance programs that are offered through pharmaceutical companies also have a designated nurse team as kind of an adjunct to what you do. So I'm just curious, do you like it when the patients take advantage of those ancillary nurse teams that are affiliated with the patient assistance programs?
Absolutely. I personally, I really enjoy them because they are, and most of these programs, they have to report back to us and provide feedback. So if they're contacted because a patient who opted into this program has a particular symptom or concern, they in many cases have to let us know. So it's an added layer of support. And sometimes they just want to go to the manufacturer or the nurse in that company and just to have somebody to talk to, and why not have that extra layer of support. I know the pharmacies will use them and link them into those programs as well. And as long as the patient's opting in and we have the lines of communication are open, absolutely, I like to refer my patients to those.
I love that, because I know a lot of times patients feel like they burden you guys all the time because they're frequent, specifically when they're initially diagnosed, they have lots of questions, right? So I feel, and I've heard this too from patients where they're just like, they feel like they're constantly burdening the office. So to your point, Beth, this is just kind of an adjunct where they can call directly to this dedicated nurse team that's affiliated with the manufacturer, right? And ask questions. So they feel like they're not burdening, you all the time. So I love that you like to take advantage of those kinds of programs. And then Nicole, as far as social worker goes, what warrants a phone call? What do you like to instruct your patients on when to call you?
Really anything. The way I kind of frame when I first meet patients is, as you're going through treatment, anything that's a stressor, and it's kind of purposefully vague because I want them to feel like, if it's something, with or not in my realm, that at least we can problem solve together. Typically it's related to coping, but it could be anything from finances, disability, wanting to know more about the treatment, goals of care. So it could be a number of different things. So I always, encourage the team also to refer to us, for any type of support services. And another thing I think has been helpful working with a multidisciplinary team, how you frame a question for a patient. Sometimes, do you want to speak to a social worker? A patient may say, no, I don't. Sometimes people don't know what that means and they feel like they're being punished, or if it's, they're just not sure. So asking a patient, can I put you in touch with a colleague for some support or resources, something a little more open, maybe more helpful for them. Or there may be some stigma attached with seeking help, asking for help. So I think, again, the more you normalize about, let me put you in touch with someone. I have a great colleague who's going to give you and your family some support. They can reach out to us, or we ask the multidisciplinary team, any staff member, to refer them to our department.
And that is such a great point, Nicole. I love that you made that, just kind of like you just said, framing the question in a different way so they don't feel like, well, should I be reaching out? Is there something wrong? Do I need a social worker? So that is a great and excellent point. So I love how you address that. And then Ori, as far as pharmacists, go, talk to me about that. As far as when they should, call you, what warrants a phone call to the pharmacist?
Yeah. So I learned this a couple of years ago when a patient, because I give them a calendar, the patient called me because they were having diarrhea. So now I make sure I include in my teachers exactly explaining when to call your team versus when to go to the emergency room or call 911 and when to call the pharmacist. I give it as an explanation saying, if you call me and you're having diarrhea, I'm probably have to go to your team because, they're going to be helping managing and I have to let them know what's going on. So I usually make it clear to them if you have any medication questions, if you're seeing another doctor and they added a medication and you're worried about interactions. I have patients calling me about, okay, I'm taking this med. Is it okay to take it with like milk or calcium? I mean, that could be a nutrition question too, but it's related to their medicine. So they're always asking about that. And then, there are some interactions with some herbal medications. So those are the things that I get called about. But most of the time, I am telling them, very clearly, the emergency side effects. I am counseling them on it, even though I tell them, don't call me if that happens, unless you couldn't reach anyone else and I'm the last person, then please call me. But otherwise, I give them like a ranking of what to do in each situation.
Gotcha. That sounds great. And then Karen, I'll round it out with you, just asking you the same question, you might be totally different in regards to the dietary aspect for your patients. What warrants a phone call to you in regards to an issue that a patient may be having?
And I think this panel has done such a great job of speaking to the breadth of patient concerns. Because it is, I like Nicole, I like to keep those doors pretty open so that patients, if they have questions about, maybe what they should eat, or they saw something on the internet, or someone at church told them that they should eat this, that they feel really comfortable calling with those kind of questions.
Yes.
As far as nutrition goes, it's rare with multiple myeloma, but certainly when patients are on nutrition support, we do a lot of education, either if they're on G-tube feeds or IV nutrition, around when to call dietitians versus when to call their home care company. And like Ori and Beth said, it is really good to have a clear designation about when to call the medical team, because yes, if somebody calls me and I've been throwing up for 10 hours straight, as a dietitian, I'm going to have to tell them to call directly their nurse practitioner or medical team or go straight to the emergency room. So it's important to open and be really invitational, that patients feel comfortable calling with lots of questions, but to have that very clear emergency route so that patients know who to call when they are experiencing what could be very serious side effects.
That's a really good point. Really good point. This next question is around the treatment paradigm, and how do each of you stay up to date or stay abreast on new treatment recommendations or new treatment protocols? And this has been a very crazy year, specifically for multiple myeloma. We've had so many new treatments that have been approved here lately. So Ori, I'm going to start with you as far as, pharmacist. How do you stay up to date with all of these new emerging therapies that have come out in multiple myeloma?
Yep. So, I'm lucky to be in a research center. So whenever we have a lot of research on these medications and once they get approved, I'm one of the people who is helping the team, transition from the research trials to the active standard of care. So that's one of the ways, I have my information from the research trials. Of course, American Society of Hematology, we have HOPA, Hematology Oncology Pharmacy Association, that has everything oncology related. And then I use my medical science liaisons. Honestly, they have so much information for me and on all these treatments. They know about their meds so well. So, this is a couple of years ago that I started doing that. And I'm like, why didn't I know this before? They have such good information and they know everything about the medication and then the trials, detailed of like all the side effects, even if it's not something that's completely like in the package insert. So I think those are the ways I keep up.
Yeah, there's a lot of good information from a lot of the, other than the MSLs, you've got the nurse liaisons, the nurse educators, the actual reps themselves. But the MSLs have great information that they can give you specifically. And then Beth, as far as you, how do you stay up as far as, an advanced practitioner? How do you stay up to date on all this great emerging new protocols and new treatments that have come out?
Oh my gosh, there's so much. I started managing myeloma patients in the mid-1990s, and we had drugs that I can count on my right hand, like very few, transplant or melphalan, and that was it, or bad. But anyhow, I shouldn't be. Anyhow, move on. Delete that. Anyhow, now I think you have to stay on all of these mailing lists. American Society of Hematology. We have the American. The ASCO. I am editor-in-chief of a peer-reviewed journal for the Advanced Practitioner Society of Hematology Oncology. So we always have updates in those. So really, and then being in a research center, you have to stay abreast of all of the new therapies so that you know what you can offer your patients. I also like to go to like the International Myeloma Foundation, MMRF, and we can look at clinicaltrials.gov. Maybe there's a clinical trial that's in the region within 100 miles, but my patient might not have, we might not have it at my center. Really linking them in with the clinical trials so that we can move the science forward is important. So not only the new updates, and again, I love using the MSLs and the treatment team and the nurse educators, I think are so important for giving us information on new approvals, but even before it's approved, getting patients to the clinical trials that will hopefully move our science forward is important.
Well, I love that you just mentioned that, because, and to your point, there might be a trial that's not ongoing in your institution. So to be able to go on to clinicaltrials.gov and find out, in my surrounding neighborhood or another institution, is there something else that a patient can take advantage of? So I love that you do that. And then Nicole, same question to you. So as far as keeping up to date on new emerging therapies, how do you stay up to date or stay abreast on those?
So, in full transparency, I don't necessarily follow the therapies. What my role would be in that realm, I guess, is making sure the patients and the providers are, having communication about what is available to them, and that patients have an understanding of what that, medication or drug entails, what that means to them, and linking them to resources so they can get, accurate evidence-based information as opposed to Googling stuff on the internet. We have a medical library where City of Hope is a research center too. So making sure that they feel empowered and confident to do research to find treatment that is best for them.
Yeah, absolutely. And then Karen, I'll throw it back to you. Same question. How do you stay up to date on these new protocols and new regimens?
Well, this year has been difficult in so many ways, but it has been really great for how much education has been online and really accessible. How many conferences went virtual and kept things up for a long time that you could go back and review a little bit more. So I've definitely taken advantage of that. And the oncology dietitians have a practice group within the Academy of Nutrition and Dietetics called the ONDPG. So often people will post on that they have a new patient on a different medication and who has experience on it. And so that has been a really great professional way. And then the ONS and ASCO and the professional organizations are great ways to stay up to date.
This question I'm going to ask right now, there's kind of three parts to this question. And I'll start with you, Nicole. So within your practice, do you offer outreach programs or local support programs to your patients? That's the first part of the question. Second part of the question is, do you find patients taking advantage of these types of programs? And I guess the third piece of the question is, do any of you have any of these outreach programs or local support groups?
Great question.
I'll start with you.
Okay.
If you need to
yes.
repeat the question, I can.
I think I got it. So to answer the first part, yes, we do have a number of both, emotional support groups and psychoeducational groups, depending on the diagnosis. We do have some diagnosis-specific support groups at City of Hope. The psychoeducational groups we've done in the past for like a kidney cancer, very kind of like specific, solid type of cancer, but we do a blood cancer, a general monthly blood cancer support group. We do a caregivers group that we've been doing for 3 years called Caregivers Connect, which is amazing. That's my baby. And we transitioned that to a virtual platform last year. So that's actually open to the community. It doesn't have to be a City of Hope patient, but we've had people from the community attend that, and they've found it to be very beneficial just to connect with others and to, virtually see that there's other people going through this and to give support, get support. But we really focus on taking things step by step, focusing on the things that can go right. And for caregivers to really put themselves first, which is very difficult when you're taking care of someone who has cancer.
Yes.
So yeah, we do find that people are absolutely making use of this. I think, like Karen brought up and a few others have brought up, the concept of telemedicine has, I think, helped with that. A lot of people were very reluctant to go to a physical location. Sometimes even coming to the hospital brought a lot of anxiety or jitters. So I think making things accessible to people through telehealth and mental health, at least, or if they're physically not feeling well, that's a huge barrier. So I do think people are absolutely taking advantage of the psychoeducational and the emotional types of support groups.
I absolutely love that you have just a caregiver support group. I think that is tremendous. And so you're the lead for that, is that right?
Yeah. Mm-hmm.
I love that. I love that. As part of like the nurse liaison role, we do patient support groups. And we've been doing a lot of virtual ones because, to your point, Nicole, a lot of people they're still, like I said, they're still a little apprehensive on getting together, in a big group. So the virtual ones have been, really nice. And, when you see the caregivers at the virtual and even in live support groups, you usually see the caregivers with the patients. But a lot of times I feel the caregivers don't really they don't have I wouldn't say don't have a voice. They just don't have a lot of time to maybe interact. It's mostly on the attention of the patient. So I love that you have just a dedicated caregiver support group. I think that's fantastic.
Been great, very cathartic for them.
Yes. And then Beth, same question to you. I mean, do you have these types of programs offered to your patients, and do you find your patients taking advantage of them?
Absolutely. We have patient navigators at our institution, and I think that many of them will help navigate that journey. Some of them are social workers, some of them are just support staff, but we have regular support group meetings. But one of the benefits that if you could call it a benefit that came out of the pandemic is that we have all of these silver surfers, these individuals who might be a little older in age and weren't necessarily technologically savvy, and now they're joining into all of these support groups and really connecting at a socially distanced way. And I think that this has changed. This last year has changed the way we're going to be moving forward. More people are more likely to engage, if not, sitting in a room and singing Kumbaya, but they're gaining education and really connecting in a little bit of a different way. So yes, we have patient outreach programs, and yes, we have them electronically, but we also like to encourage to tap into the International Myeloma Foundation, and the Multiple Myeloma Research Foundation has lots of support groups. And then there's other groups out there, but those are the key ones that I tend to refer to.
Yeah, I love that. Love that. I love that you take advantage of, the MMRF and the IMF. They're such great organizations, and they have so much great information for patients. So I love that. And then Ori, I'll throw it over to you in regards to, what does that look like at Dana-Farber in regards to outreach programs and local support groups?
Yep. So we have a center that's for resources. So this center, when a patient walks in, it's a physical center where you walk in and there's like all these forms, education stuff. But in addition to that, they do a lot of the other things, like they do massage therapy, they do Reiki, which I don't know if it's happening now, but patients used to take advantage. When they're in clinic, someone comes and they're massaging their hand, or they can go to the place for a full massage. So they actually love that. And then in addition to that, after every conference, usually some of the team in myeloma, they put together like a conference for patients, because some of these patients want to get updated, what happened at ASH, what happened at ASCO. So they put a team with more of the basic information of updates to patients on, what happened in these conferences for people who want even more information. And of course, we have the support groups for every disease has it, but it's mostly a support group for patients.
Do any of your support groups, your local support groups, ask like yourself to come and talk with them on some of these new therapies that have come out? Do you ever get asked to join their group and talk about those new therapies?
I know one of the other pharmacists used to do that, but I haven't been asked. Maybe I should tell them that I'm available, but it's usually, I know one of the pharmacists does a lot of talk about adherence, She talked about, how to adhere to your medication. What are some ways to, make a calendar, a pill box, or whatever different ways to help.
Yeah, absolutely. And then Karen, as far as City of Hope, what kind of outreach programs or local support groups are offered for patients?
Well, it's been a great experience. For Texas Oncology, we have the medical piece, and then we also have a nonprofit piece. So the social workers at Texas Oncology offer patient support groups through, they can sign up and everything is on our patient portal and everything's virtual, and they've divided it in between kind of more education-oriented sessions and then more connection-oriented sessions, which has been a nice balance, I think, for people. And then the Texas Oncology Foundation has put together a couple virtual camps through Facebook, which people really like, and they have kind of a 4-week curriculum of speakers and demonstrations. And in fact, I just did my session for them yesterday on the new dietary guidelines that came out as part of for their virtual camp. And then they also run a caregiver support group, which is also very near and dear to my heart. And I think the virtual support groups for caregivers are such a good benefit because there's that kind of tension between leaving your loved one who you know is sick to kind of come into a space with other people. Whereas with the virtual ones, they can either be close by or know that they can be somewhere very quickly if their loved one has needs while they're in a support group.
Yeah.
So it's been a really nice way.
And I apologize. I said City of Hope. I meant to say Texas Oncology. So I'm so sorry about that.
That's okay.
I love that camp idea. I have never heard of that, like a 4-week type of camp. I think that's an awesome idea. Love that. And then the last question, because we got about 5 minutes left. The last question is just involving like the cadence of involvement from the support team. So for example, let's say a patient calls into the office with a GI side effect and the nurse gets the call. How do you guys as a support team come together, and how does your involvement, what's the cadence of your involvement? How does the nurse pull in the social worker, or how does the nurse pull in the dietitian? Mm-hmm. So actually I'm going to go and actually ask Beth, what does that cadence of support look like?
Right, so I think we strive to address urgent concerns by phone immediately. And so oftentimes it's the triage nurse or somebody it's taking the phone call that will send it off, and they'll page out an urgent side effect. But this is why I think it's important to set up monitoring for certain medications, especially more in the first month or 2 of therapy, and then have visits in the treatment area or scheduled phone encounters virtually. So they're taking oral medications, they don't have to come home, but you call them on the phone and then you say, so how are you doing? What are your side effects? And sometimes they don't want to call in and bother you. Nobody's ever a bother. I shouldn't say it like that, but people don't want to, they say, oh, you're so busy, I don't want to call. But that's not the case. We want to learn about the side effects because then we can't help you through them if we don't know. So again, usually they call into the office. Sometimes they send electronic message, but oftentimes we try to be proactive and put through those resources ahead of time so that they don't get to where they have to call in and have a problem.
Gotcha. Excellent to know. And then Karen, just the same question to you, the cadence of involvement for the support team. I mean, how do you guys, how does that come together as a support team?
So there are some pathways built into the electronic healthcare record where you can send consults or messages directly to someone's inbox within the chart, which is, I know, a part of most electronic healthcare records these days, but I think that has been a nice way to get people involved because it keeps everything in the same system. So you can really see who's been consulted or when and what other support has been brought into, which is a really nice way to see the whole multidisciplinary team. So that's been one of the ways that we've incorporated that cadence or that involvement.
And then Ori, I'd love to hear your feedback on how that cadence of involvement, what that looks like for you.
Yeah, so I think it's funny, how Beth says patients think they're bothering by calling you. I have a big team that I work with, so sometimes they don't want to bother me. because they know, I'm helping all of them. It's one pharmacist for like 10 providers. So, but I do tell them, and they know, if a patient has a question about a side effect, nausea, vomiting, I can go over their medications with them. So they know to email me, call me, page me, in basket, any type of way. But most of the time, they're trying to take care of it, or the nurse navigators are the first ones who are getting the message. They try to contact the patient, and then if they're stuck somewhere, usually they will go to the team and they're like, okay, Hootie, can you help with this, with the patient? So I try to be like maybe the last person before, they say, okay, we really need like someone else to take care of this now. Especially if they're in clinic and if they're busy, they would come to me first. Otherwise, they would like try to take care of the patient, because some of the times they know the patient much more than I do. So I have to go through the history and exactly know what's going on.
Gotcha. We've got about 2 minutes left, and I would just kind of like to throw it back to each of you to see if there's any additional comments you guys would like to make.
Yeah, I can start. I just want to say thank you. I learned a lot from this group. And just one thing that, I wanted to talk about it and we didn't get a chance in between is the importance of, when I'm counseling the patient, and I'm sure everyone else is the same, asking the patient to repeat back what I'm telling them. Sometimes it's very hard for them, if I'm giving them too much information, I'm always at the end, I'm like, okay, tell me, how are you taking your medication? What time are you going to take the medication? When are you going to call? So I think that's something we didn't talk about. So I just wanted to bring in, because I'm not going to be able to sleep tonight if I don't say it.
I love that. And that's such an awesome thing to do. Absolutely.
Mhm.
It just puts, makes it sure, or you make sure that the patient is understanding what you're saying. So I love that you have them repeat that back. Anybody else want to make any additional comments before I let you guys go?
Just really thank you. This being a part of the multidisciplinary panel in a way that highlights the importance of the multidisciplinary panel. I love that it works on so many levels, and I've been so grateful to be a part of this. So thank you.
No, thank you. Appreciate your time. Anybody else before I let you guys go? Well, first of all, thank you again for your time. And Beth, you mentioned it at the very beginning, it takes a village, and it truly does take a multidisciplinary team to aid in a successful patient journey with their cancer diagnosis. So your time has been greatly appreciated. So thank you so much.
Thank you.
Have a good rest
You
of the day.
all.
You too.